Let's join Dr. Gary Levine for a discussion on managing common cutaneous problems.
I'm going to show you some skin. Some references for you. Dr. Charles Phillips at our institution, Dr. Richard Usatine at UT San Antonio, who is Mr. Dermatology or Dr. Dermatology and Family Medicine. If you want a good textbook, I would recommend the one by Habif. Some of the images we're going to see are from the CDC and from Jefferson in Philadelphia. If you want to know what dermatologic things to study for your exam, I recommend you go back to the future. Go to the AFP Journal 1999, where they published a curriculum guide for family medicine residents in dermatology. A lot of those, or almost all those entities, are still with us today. The information's changed, but if you want to know what to concentrate and study, I would go there. The board typically asks two kinds of dermatology questions: those with questions and those without questions. Those with pictures, those without pictures. And we're going to kind of go over mostly those with pictures today. We're going to talk about a lot of different dermatologic entities, and with all due respect to Gilbert and Sullivan, we're going to talk about macules, papules, and nodules, plaques, pustules, vesicles, and bulli, wheals, scales, crusts, erosions, fissures, and scars. And we're going to do it at light speed, so hang on to your chairs. Question number one. Do you see this one okay? 45-year-old male presents with chronic rash present over his knees and his elbows. Which of the following represents the most likely diagnosis? Tinea corporis, psoriasis, mycosis fungoides, or Bowen's disease? And you voted for psoriasis. 1% of you got it wrong. I'm sorry. This is psoriasis, a plaque and scale-like illness, psoriasis, cutaneous lupus, tinea corporis, Paget's disease, lichen planus, Bowen's disease. These all have plaques and scales. Here we see typical tinea corporis, a well-defined border, central clearing. Pityriasis rosea, kind of scaly. You may see the herald patch, or you may not. Bowen's disease, a precursor for squamous cell carcinoma. Ichthyosis, fish scale disease, diffuse, often hereditary. Lichen planus, more purple, violaceous, itchy, chronic. Psoriasis, which is what our patient has, as we see here. Psoriasis typically is oval erythematous plaques. Overextends their surfaces. Look for them over the elbows and knees in the scalp. You may see arthritis. You may see pitting of the fingernails as well. Different psoriasis types. Most common is the chronic plaque-like psoriasis. That's the one the board will probably show you. How do you treat psoriasis? With less than 5% involvement, topical steroids, calcipotriene, which is a vitamin D analog, tazarotene, anthelins, dyes, like we have TARS. We've used those in the past. More than 5%, you're starting to get into the realm of phototherapy, which is more the dermatologist than us. If there is arthritis with it and it's severe, then we're talking about disease-modifying agents similar to what we use for rheumatoid arthritis, methotrexate, the anti-tumor necrosis factor agents. All right, case number 2. 65-year-old lady has a painful rash on her face, one side of her face to be exact. Which of the following therapeutic modalities be most beneficial in the initial stages of her illness? Prednisone, valacyclovir, silver sulfadiazine, or gabapentin? You voted for valacyclovir. Good, because why? Our patient has herpes zoster or shingles. Zoster creates bullous lesions. Herpes simplex, zoster, impetigo, dermatitis herpetiformis, burns, bullous pemphigoid, pemphigus vulgaris, some erythema multiforme can be bullous. Here's bullous pemphigoid. See this more often in the elderly. Typically, the bullae is kind of full. If you press on it, it doesn't expand laterally. If you rub an eraser on the skin and the skin comes off, or you press on this bullae, it expands laterally. That's called Nikolsky sign. That you see with pemphigus vulgaris, which is a much worse disease. Second degree burn is blister. First degree is sunburn. Third degree, scars. Erythema multiforme, most often target lesions like you see here. Occasionally they can be bullous lesions as well. Our patient has zoster, as we know, a reactivation of a latent infection from chickenpox with that varicella zoster virus. It usually involves one dermatome, sometimes adjacent ones. If you're able to diagnose shingles in the pre-eruptive phase before the rash occurs, your reputation is great in your community for many years to come. Look for vesicles on a erythematous base of various sizes. They come in crops. If they all come looking exactly the same at the same time, then notify Homeland Security. That might be smallpox. Postherpetic neuralgia, that's what we worry about. The more pain the patient has with the rash, the older they are, the more likely they're going to have this later, and the incidence about 20%. How do you treat zoster? Analgesics for pain, wet compresses, the antivirals. Dr. Weissmiller probably told you about them for genital herpes. It's the same group here, but the dose is a bit higher. Steroids, used those in the past, found that they don't reduce the incidence of postherpetic neuralgia, so we kind of got away from using steroids. How do you treat the neuralgia if you get that? It's a very painful condition. Analgesics, potentially including opioids, anticonvulsants, tricyclics, sympathetic nerve blocks. You got to time that right. Not wait too long, doesn't work well, not too early, because you may not need it. As we know, there's a vaccine, Zostavax, for herpes zoster. There's now a new one that's come out called Shingrix, which is availability is kind of limited in some areas. The Zostavax, the live attenuated vaccine, like the Viravax at a higher dose. The Shingrix is actually a dead virus. Shingrix is given 2 doses, the Zostavax just in 1. You don't need to check for titers or past history of zoster. You can give that with either of those vaccines. But don't give the Zostavax to someone immuno-incompetent because it's a live virus vaccine. 25-year-old male, known HIV infection, lives in the same substandard housing we give for students and residents, and has a generalized pruritic rash. So which of the following represents the best treatment for this condition? Is it prednisone, hydroxyzine, permethrin, or Bacavir? And you voted for permethrin, great, because our patient has scabies. Papules, particularly pruritic papules. We see that in miliaria, atopic dermatitis, urticaria to a certain extent. Insect bites, scabies, the eruption in HIV, the PUP that we see in pregnancy. Here is atopic dermatitis. This is on flexor surfaces, so the opposite of psoriasis, which is on extensor surfaces. Urticaria, hives, sometimes may look more papular than this. Scabies is what our patient has. Scabies is a hypersensitivity reaction to the mighty mite Sarcoptes scabii. We don't give it under the skin plumbing, so it lays its eggs and feces under our skin, and we have a reaction to that. And the mites like to run around at night, so we itch more and spread it at that time. Look for the presence of a burrow that tells you the mite's been burrowing. Look for them in the finger webs, but you can see them just about anywhere. In adults, since it's sexually transmitted, the genitals are a place to see them as well. So here's a scabies burrow, not that easy to see. One way to see it easier, if you think it's there, is take a felt pen and then color over it. The ink will get into the burrow, you then wash off the skin, and you can see the burrow better. Then scrape it, and if you are lucky and the patient is not, you can see the mighty mite or the eggs and feces, as you see there on the right. The eggs and feces are called Cibala, and you're not going to see that on your boards. Norwegian crusted scabies is an overwhelming infection in HIV patients or immunocompromised patients. Not all that itchy, not easy to deal with. How do you treat scabies? You launder all bedding and clothing, then 48 hours in hot water. You put it in a bag to suffocate the mites. Treat the patient, their household contacts as well. How? Permethrin 5%, below the neck typically. Scabies doesn't typically get above the head. You can do it again in a week, but you don't have to. In the past, we used Lindane. Stay away from Lindane. It's too toxic, especially for kids, and it's not used at all in pregnancy. Ivermectin for Norwegian scabies or resistant cases. This is Rhus dermatitis, also known as toxicodendron dermatitis. We call it poison ivy dermatitis. You get this when you get in contact with sap from a plant that is in the Anacardiaceae family, the Rhus genus. Poison ivy, poison oak, poison sumac. In Hawaii, a lot of people get this from peeling the skin off mangoes. The ubiquitous Japanese lacquer tree that we all have in our backyards. You can get it from that. You get linear lesions, vesicles, it itches, it's red. You can see this as early as 8 hours or up to a week after exposure. Decontamination is helpful only for about 10 minutes or so. Acutely, wet compresses, topical steroids, high potency, if there are minimal lesions. Anything more than that, we're now recommending systemic steroids. That's a prednisone taper, typically over 2 weeks, or a lower dose twice a day for 1 week, or an IM triamcinolone injection. Here's contact dermatitis. You can kind of visualize the watch band with nickel that was underneath there. All right, case number 4. Hope you can see this one. 55-year-old congressman complained of a new rash, a few localizing lesions on his chest, after returning from a business trip with a female lobbyist. He admitted to spending an inordinate amount of time having meaningful conversations with her in a hot tub regarding the budget. Which of the following would you recommend for the management of his condition? Oral cephalexin, no pharmacologic therapy, but stay out of hot tubs. Oral Bactrim or topical clotrimazole. You voted for a tie between the second one and the third one. The correct answer is actually the second one, but we'll talk about why you may have chosen Bactrim. This patient has a folliculitis, particularly a hot tub folliculitis. Folliculitis is a superficial infection of hair follicles. If these hair follicles kind of get together, then you can get a boil or a furuncle. And if they further coalesce, you can get a bad inflammatory mass called a carbuncle. Here is a furuncle waiting for Dr. Bard Parker to come by and liberate its pus. Psychoses barbae. This is folliculitis in the beard area of the face. What causes folliculitis? It's usually staph. So if you were thinking Bactrim, treating MRSA, you weren't thinking all that bad. No, not at all. But in the hot tub folliculitis, it's usually Pseudomonas or Aeromonas, a different pathogen. You can also see it from Candida and rarely from non-TB mycobacteria. With folliculitis, the good news is the lesions usually get better on their own, but if they're extensive, last longer than antibiotics are typically used. Warm compresses help with the drainage process. Don't shave in involved areas. With hot tub folliculitis, again, stay out of that water. It's contaminated. Most cases don't need further treatment. But if they're bad or progressive, then things like ciprofloxacin, which covers Pseudomonas, would be the way to go rather than Bactrim. Staph folliculitis, well, mild cases, Bactroban if you need to treat it. More severe, and you're not worried about MRSA, dicloxacillin or Keflex, you are worried about MRSA, there's your Bactrim, clindamycin, or doxycycline. Pseudofolliculitis barbae, not a folliculitis at all. In the South, we call them hair bumps. Hair, short, curls back in the skin, causes inflammatory response. You kind of massage them to get the hair to get out of the skin, or you do what I do and you don't shave. Impetigo, Bacterial infection again, typically in the facial area. We see this typically in kids aged 2 to 5. Primary impetigo is on intact skin. Secondary is often kids who've had trauma or have underlying eczema. Non-bullous impetigo, the most common form, in the past was kind of half staph, half strep. Now it's almost all staph. Bullous impetigo, always staph. These villi are yellow or turbid looking and need to be often ruptured and drained. Strep impetigo can cause rheumatic fever and post-strep pneumonitis, but again, it's really rare these days. How do you treat impetigo? A few lesions. Mupirocin will work. Altobox will work. More lesions or antibiotics against staph, particularly MRSA if you're worried about that. Erysipelas, another bacterial skin infection, but this is strep. These have well-demarcated margins around this red edematous area. These people can get pretty toxic and sick, often elderly, often needing IV therapy. Case number 5. 16-year-old female, like to be treated for this facial rash not responded to over-the-counter cleansing preparations. Her high school prom is 3 months away. She's not sexually active. Yeah, but the prom's coming. So which one of the following would you recommend management of this condition? Topical retinide alone, topical clindamycin alone, topical retinide plus topical benzoyl peroxide plus oral doxycycline, or isotretinoin. You have chosen the third one, and you've chosen wisely, because that is indeed correct. What's our patient have? Acne vulgaris. Here we see a few more pictures of pre-inflammatory acne. So what is acne vulgaris? It's an androgen-related disorder. Androgens, when they kick in, stimulate sebum production and proliferation of keratinocytes. They produce keratin, which blocks the outflow of the follicle. Bacteria, Propionibacterium acnes, gets in there and then multiplies, causes inflammatory substances to be released, and that causes the lesions that we see. You can see closed comedones and open comedones, nodules, papules, pustules, and or scars. Here we see a patient with a moderate inflammatory acne on the forehead. Here we see one again around the lower face. Here we see a lady with a cyst on the forehead and the dreaded black rectangular eye syndrome. Lesions of acne are seen more often where there is more sebaceous glands: face, chest, upper back, upper arms. Well, how do you treat them? Comedoneal acne, use a keratinolytic agent. Mild inflammatory acne, use that and add to it benzoyl peroxide or benzoyl peroxide with a topical antibiotic. For moderate inflammatory acne, we kick in a systemic antibiotic typically, and for nodular cystic acne, that's when you start thinking about isotretinoin. What are our topical keratinolytic agents? Tretinoin or Retin-A, adapalene. The Retin-A is a bit irritating. Use a low concentration to start in the evening. Let the patient know it's going to be irritating, and that's how it works. Adapalene works just as well as Retin-A, less irritating. Also, you can combine adapalene with benzoyl peroxide. You don't typically want to mix the Retin-A with it. Tazarotene also can work for acne as well as for psoriasis. It is teratogenic. Azelaic acid, both keratinolytic and anti-inflammatory, but may be hypopigmented, particularly in darker-skinned individuals. Topical antibiotics, benzoyl peroxide. We use this like water because there's no resistance to this yet. It does, however, bleach your clothes and your hair. If you use another topical antibiotic like erythromycin or clindamycin, you ought to combine that with BP to avoid resistance in your patient. Erythromycin, clindamycin, tetracycline, again, don't use them alone. Metronidazole can be used by itself. Dapsone, newer agent, uses more in women with inflammatory acne. It's expensive. Systemic antibiotics, again, for moderate inflammatory disease, Tetracycline's been used for a long time. Don't use them in kids, obviously. Minocycline, no more effective than tetracycline, but more side effects. Doxycycline, usually preferred, easier to take around food. You do have an incidence, however, of photosensitivity. Systemic antibiotics, erythromycin, azithromycin, Bactrim can be used, but again, watch out for resistance. If you use an oral antibiotic, limit that to no more than 3 months. You can switch abruptly from oral to topical without a taper. Oral contraceptives, particularly those with certain progestins, have been FDA approved. Spironolactone, also anti-androgenic, so it's helpful. Again, use those combinations in women, not in men. Isotretinoin, the only thing that can cure acne. It's a 12 to 20-week course, but lots of side effects. And it is highly teratogenic. So if you prescribe that, your patient and you have to both go online, the iPledge program. Basically, patient pledges not to get pregnant, take 2 kinds of contraceptives, and not get in trouble. There are light-based therapies. Again, more the realm of the dermatologist. The board's not going to ask you about that. If you like to be a surgeon, you can extract comedos. It's a lot of fun. You can drain abscesses. You can inject cysts with some triamcinolone. There is an alternative treatment that has some evidence of effectiveness, topical tea tree oil, but it's slow onset, and the effectiveness is not all that great. Who goes to a dermatologist? You should refer them to patients with refractory lesions. Despite your therapy, if you think isotretinoin, you may want to let them start it at least. And acne scars are hard to manage. Let them do that. Remember that acne vulgaris is the most common skin condition seen by family physicians and by dermatologists. Rosacea. You may hear this referred to as acne rosacea. Here we see another picture of rosacea. And another. Prevalence 15 million in the US. Look at this in patients of Celtic ethnicity, more common in the 30s, in women. Don't know what causes it. Some enthusiasm even for a mite infestation. See it around the forehead, the eyes, and the face. The board may ask you or give you a question that describes 3 primary features. Ask you what it is. Erythema, that may be transiently flushing. Papules, pustules, and telangiectasias, the 3 components of rosacea. You may also see a bulbous nose called a rhinophyma. W.C. Fields was the poster child for that. Things that cause triggering of that rash of flushing in rosacea, same things that cause flushing in general. Temperature, heat, sun, spicy foods, alcohol vasodilates, niacin vasodilates, things like that. How do you treat rosacea? For papular pustular involvement, metronidazole works well, as does benzoyl peroxide and lazelaic acid. For the erythema, brimonidine is available, but it's pretty expensive. Carvedilol can be effective in reducing flushing. Oral antibiotics, the same group we use for acne vulgaris, can work for papular pustular lesions. Retinoids may be curative here as well, but again, it's a difficult treatment course. Now, this is a patient who has seborrheic dermatitis, the greasy looking around his nose. This is seborrheic dermatitis around the mouth and lower part of the nose. This is biphasic. In young kids, the cradle caps. Also, look for, if you see in adults, look out for HIV and Parkinson's disease, because you will, in fact, will see that. How do you treat seborrheic dermatitis? Low-potency steroids on the face or topical antifungals. For the scalp, selenium sulfide shampoo works pretty well, as does ketoconazole shampoo. Perioral dermatitis, often confused with acne. The typical history is the patient has these bumps, put some steroids on them, and they get worse. Typically a younger person around the facial area. Mild involvement, you can use metronidazole topically or topical pimecrolimus. More than mild involvement, the same antibiotics we use for acne vulgaris. This is lupus erythematosus. This is systemic lupus, in fact. The malar butterfly rash, the mask of the wolf, as they say. Lupus can be chronic cutaneous lupus, subacute, or acute cutaneous lupus, depending on how it looks. Most people with lupus have some rash at some time in their course of therapy, the butterfly rash being the most common. It does get worse in the sun, tends to spare the nasolabial folds, unlike the other disease we talked about. Here we see another patient with discoid lupus. This tends to, again, be a scarring condition, very disfiguring. How do you treat lupus rashes? Keep them out of the sun, tell them to stop smoking, typically topical steroids, maybe high potency. You can also use topical calcineurin inhibitors, and if you need to, systemic antimalarials. Case number 6, moving on. The case of the spotted man. 21-year-old male, pale spots on his back and his upper chest. Despite treatment with a topical agent, they're unchanged. We should now be treating them with which of the following? Benzathine penicillin G, pimecrolimus, oral fluconazole, or prednisone. Your choice is oral fluconazole. Great. We're really doing well on these questions as well. Our patient has, as you suspected, tinea versicolor, fungus of many colors. These are acquired hypopigmented lesions. Pityriasis alba, vitiligo, tinea versicolor, post-inflammatory hypopigmentation, which is common. We don't see a lot of leprosy, however. Pityriasis alba. This is a child. You can see the paleness on the cheeks and upper forehead. We don't know what causes it. It tends to get better on its own. Sometimes steroids topically may hasten that. Vitiligo, autoimmune, associated with other autoimmune processes like Hashimoto's thyroiditis B12 deficiency. And we have tinea versicolor, fungus of many colors, caused by Pittosporum species as the lesions convert from budding to mycelial form. This happens with heat, humidity, and lots of sebum, so more common in younger people in the summertime. Lesions begin as circular macules that enlarge, tan, dark brown, often with a little fine scale to them. They have a pottery scale, you know they're active. If you put a Woods lamp on them, it will fluoresce kind of a yellow color. How do you treat tinea versicolor? Limited disease, use topical agents, ketoconazole, selenium sulfide, terbinafine do work. If there's more extensive disease or non-responders, you can use oral itraconazole or fluconazole. Don't use oral ketoconazole because of hepatotoxicity. If they have lots of involvement and continue to do so, you can use prophylactic treatment for them. Tinea versicolor, part of the tinea family. Tinea means fungus. We classify it by site. Tinea capitis, tinea corporis, tinea pedis of the feet. By others, including tinea versicolor of multiple colors. Tinea glanatorum, we see that in wrestlers. Tinea incognito, we see that in FBI agents and ex-FBI agents these days, I guess. Here's tinea corporis, again, clearing centrally, well-defined margin. Here's tinea incognito. No, not an FBI agent. This is tinea treated with steroids. Now you can't tell what the heck it is. That's what makes it hard. Erythrasma. Oh, the board loves erythrasma. Typically have questions on it. Erythrasma is a bacterial infection, typically in the breast, the axilla, the groin, same places you see tinea cruris. The difference is if you shine a Woods lamp on tinea, it's yellow-green fluorescent. If you shine a Woods lamp on erythrasma, it's a coral pink, orange, red fluorescence. The board likes to ask you that. Treatment is typically different. We typically use antibacterials of the erythromycin macrolide group to treat erythrasma, though there is a study that shows clotrimazole will work as well. But erythrasma, think about macrolides. Coral pink fluorescence, think about erythrasma. Tinea capitis, loss of hair and patches on the scalp due to fungal involvement. There can be an inflammatory process with this called a carrion, with a K as opposed to a C, which is what vultures go after. If you see tinea capitis, the board may ask you how you treat it. And the treatment is oral antifungals, griseofulvin or terbinafine. It is not topical therapy. Don't fall into that trap, either clinically or on the board exam. Itraconazole, fluconazole. If you have an inflammatory boggy carrion, then adding some systemic steroids may help reduce the inflammatory response. And consider treating household contacts, antifungal shampoos. Traction alopecia. This is a person who braided too vigorously and you're putting traction on the hair and it's falling out. Androgenic alopecia, a male pattern baldness in men or sometimes seen in women. Alopecia areata, another autoimmune process. Hair comes out typically in patches. If you pull out one of those hairs from that patch, look at a microscope, it has a narrow proximal end and a bulbous distal end, an exclamation point hair, as they say. Rarely, all the scalp will be lost of hair. Even more rarely, the whole body hair will be missing. How do you treat alopecia areata? Corticosteroid injections in the scalp, topical minoxidil. Wigs work well, waiting for hair to regrow. Prognosis, pretty good, 50% limited patchy hair loss recover within a year, but it may take longer. Only 10% do not regrow their hair. Speaking of hair, what about pediculosis capitis? You've all probably run into that. Here is the pediculosis herself, posing for her prom picture, kind of a golden, cute-looking thing. How do you treat head lice? Pyrethroids are first-line treatment, malathion, second-line, topical ivermectin may be used for resistant cases. The important thing here, and the board may ask you, is that the pediatricians and the CDC says you don't need to keep these people out of school once you start treatment and go right back. Household members, close contacts should be examined and treated, and also treat those who share bedding with the affected individual. Melasma, not hypopigmenting, but hyperpigmenting, the mask of pregnancy. Case number 7. Can you see this one okay? 26-year-old male dermatology resident presents to your office complaining of a new patch of warts on his penis. Funny you should ask, my girlfriend has some of these umbilicated papules on her bottom as well. Umbilicated papules. So the most likely cause of his lesions is Treponema pallidum, herpes simplex, human papillomavirus, or molluscum contagiosum virus. Go pick one. And you've picked molluscum. Excellent. That's what this patient has. If the board shows you something, you can't make anything out on it, and they say in the description, umbilicated papules, that's the only thing it can be, molluscum contagiosum. Genital warts can be these cauliflower-like lesions, and they can be pretty disfiguring. Warts due to HPV infection, lots of different types. Type 1 is plantar warts, 6 and 11, genital warts, and they're spread by contact. How do we treat them? There are patient-administered treatments like Podophylax and Micromod, Senoketchins, all expensive. Or they can come to the office and we can freeze them, or we can use acid on them, or we can laser them. The CDC doesn't want us using the old tincture of podophyllin, tincture of benzoate anymore, because they think that that's too toxic to surrounding tissues. Common warts, as you see here. A good clue that a lesion is a wart is you look at the skin lines, follow them to the edge of the wart. If they disappear at the edge, it's a wart. If they go through the lesion, it's probably a callus. Here we see some plantar warts, exophytic ones. This is a callus, in fact, in a diabetic patient. You can treat warts with duct tape. Usual recommendation, if you do that, put some compound W under it. Probably work a whole lot better. Genital herpes, as we've seen, Dr. Weissmiller told us about genital herpes, and treat that with the big 3, acyclovir, famciclovir, and valacyclovir. Molluscum contagiosum, what our patient has. Here we see the umbilicated papules. double-stranded DNA pox virus, skin-to-skin contact, umbilicated papules. Kids get them all over, adults typically in the genital area. How do you treat molluscum? You can leave it alone. It will eventually go away. But while they're there, the patient's contagious. So cryotherapy, curettage can get rid of them. Just don't harm your patient in the process of treating them. Case number 8, the case of the Golden Dome. 68-year-old male sent in by his daughter concerned about a growth on father's scalp. Which of the following is most likely? Keratoacanthoma, dermatofibroma, sebaceous hyperplasia, basal cell carcinoma. Your vote for basal cells, which is good, that's right. This is a basal cell carcinoma. Basal cells are nodular lesions. Basal cells, squamous cells, keratoacanthomas, sebaceous hyperplasia, melanomas, neurofibromas are all there. Here is sebaceous hyperplasia, kind of a multi-lobe lobes within the nodule, telangiectasias confined to the lobules, tend to be multiple. If you want to see a few of these, come up after the lecture. I'll show you the ones I have on my face. Keratoacanthoma, a precursor for squamous cell carcinoma. Basal cells, most common skin cancers, men more than women, head and neck area, middle-aged individuals. Nodulars, the most common, thankfully least aggressive. Superficial, sclerosing, and pigmented basals can occur. Here's a nodular basal cell. Here's another one, easy to figure that one out. Here's one kind of eroding in front of the ear, not good. A superficial basal cell, a little bit more difficult. Sclerosing or scarring one, quite difficult to diagnose. Treat basal cells by excising them. Small ones can be also treated with cryo or desiccation. If they're sclerosing, though, if they're large, margins are not clear, they're in high recurrence areas or where skin sparing is important, then welcome them to Mohs, microscopic mammographic surgery. For non-surgery candidates, you can use radiation, imiquimod, 5-FU. Actinic keratoses. Here we see more of them. They occur in older individuals in sun-exposed areas. Rough scaly patches, you can feel them often easier than you can see them. Multiple asymptomatic. So why in the heck do we worry about them? We do because they're premalignant. They're the most common premalignant lesion that dermatologists see. They may progress to squamous cell carcinoma. Most of them do not, thankfully, but most SCs occur from AKs. Treat them, therefore, with cryotherapy or curettage. There are some phototherapies that can be used. Patient has a lot of them. You can send them home with a prescription for 5-FU, imiquimod, diclofenac, or Ingenol. Again, warn them that they may biopsy, their wallet may suffer as a result. They're expensive. Bowen's disease, again, a precursor for squamous cell carcinoma. We saw keratoacanthoma, a volcano-looking lesion. And squamous cell carcinoma, the big kahuna here. Precursors, AK, cutaneous horns, Bowen's disease, chronically injured skin, UV radiation. You diagnose them often by a shave technique or a punch biopsy. Then excision is typically what we recommend. Radiation if you can't take them out. Case number 9. Case number 9. 55-year-old man, these skin lesions at the time of routine exam. Which is following the most reasonable course of action? Treating with 5-FU, observing them, excising them with a wide 4-centimeter margin, or referral to Mohs micrographic surgery. And the answer is B. Yeah, good job here. Why? These are seborrheic keratoses, very typical looking. These are pigmented lesions, intradermal nevi, melanomas, SKs, Kaposi sarcoma. Cherry angiomas are pigmented. Here we see a cherry angioma. We see this in the hospital. We rush all the third-year medical students in so they can identify one dermatologic issue before they graduate. Hemangiomas, more of these often in kids. Pyogenic granulomas, if you touch these and try to manipulate them, they'll bleed like stink. Atypical nevi here, Atypical, dysplastic, no big deal, except it looks like this. Not with a malignant melanoma, which is a big deal. That's what we worry about the dysplastic lesions. Here's another melanoma, more of a nodular component. You're not going to miss that. Melanomas, mostly in Caucasians, in their 50s, men more than women. We worry because they metastasize quickly. The risk factors for melanoma: large number of nevi, other cancers, congenital giant nevi, positive family history, radiation, or immunosuppression. Subtypes include superficial spreading, nodular lentigo, and acrolentiginous melanomas. Remember the A, C, D, E, A, B, C, D, E, and U's of melanoma? Asymmetry, border regularity, variable color, diameter over 6 millimeters, evolving lesion, and one that looks different than the other nevi, the so-called ugly duckling sign. Here's a superficial spreading melanoma, a nodular melanoma, you're not going to miss that one, a lentigo melanoma, an acrolentiginous melanoma. You may see people who are darker skinned may have vertical streaks in their fingernails. Multiple nails, don't worry. A more pale person with a single nail and nail bed involvement, that's a melanoma. With melanoma, the thickness determines prognosis. You may have heard of the Breslow stage, the Clark level. Those are just pathologic stages. Our patient has an SK, and there's lots of them. If you're worried about melanoma, do a full thickness biopsy. You don't need a wide excision. If you're certain it's an SK, you can destroy it with cryo or curettage, or just watch it. Watch out for the sign of lesser tralot. All of a sudden, somebody gets all these SKs on their trunk. If you see that, there may be an underlying abdominal malignancy. The board could ask you about that. Dermatosis papulosa nigra, an SK variant on the face and neck, and skin tags, which you may also see in patients who have insulin resistance. One last case, if I have a couple more minutes. Case number 10. 39-year-old lady, lump on her back, gotten bigger and smaller for a couple years, occasionally drains some cheesy-looking material. You tell her the material within the lesion is most likely which one of the following: keratin, sebum, pus, or cheese. Yeah, just like the others. It's keratin. We call them sebaceous cysts, but it's keratin. These are epidermal cysts. Here's some more. Here's one that's starting to drain. Epidermoid cysts, epidermal inclusion cysts, sebaceous cysts, we call them the same thing. The cyst wall produces keratin, not sebum. They may enlarge or rupture. Inflamed and unruptured, infected cysts can be treated with steroid injection. If they're infected and worse, then you excise them, especially if they're infected. Or antibiotics, if they're surrounding erythema, warmth, fever, or not responsive, and you treat them mostly for MRSA. Here's a lipoma, a keloid, disfiguring keloid. We treat keloids with intralesional steroid injections. You blanch the lesion with the injection. Neurofibromas, look for these lesions and cafe au lait spots and a positive family history. Xanthelasmas, lipid deposits in the eyes, not always associated with lipid disorders, however. So here are your answers. We got most of these right, and I think we're ready to do well on the boards, the SMART group.
Thank you very much, Dr. Levine.